Okay, so this is task 6. I'm not using notes. This is monitoring anesthesia using an anesthetic chart. So this is just the CT or the video paper instruction thing that I'm using. There's nothing written on the back or anything like that. Let me get this one back here. So this is just our anesthesia log forms that I showed you in the previous videos. So essentially, what we're going to talk about is everything else on this paper. Heart rate is for dogs is anywhere between 60 to about 140. I'm trying to get my seat a little more cooperative. So anywhere from between 60 to 140, and then big dogs are about 60 to about 100, and then little dogs, their heart rates are anywhere between 100 to 140, and then cats are about 140 to 220. It's important to know what the heart rate is, just because that kind of lets you know, gives you an idea of what their anesthetic plan is if they're going to be under anesthesia. Plus, obviously, the big no-brainer is that, well, they're alive. So that's one of the reasons why it's important to know what the normal heart rate is for just regular dogs and cats, even if they're non-anesthetized, they're awake. Obviously, if they're in too deep with anesthesia, their heart rate is going to decrease. And I'll get to that in a minute. Heart rhythm, it's important to know that. Sorry, I keep looking behind y'all because my doctor's right there. The heart rhythm, the reason why it's important to know the heart rhythm is because there can be a potential for an arrhythmia or what have you, just any abnormal rhythm of heart with anything other than a normal lead dove sound is not normal. So if you're hearing anything other than a lead dove, obviously it's not normal. Mucous membrane color. Normally you want pink, nice pink, moist gums. And sometimes dogs and cats, not typically cats, but sometimes dogs and cats will have black gums, so they will have. It's a little more difficult to check their gum color, so you can always check their the pinna of their ear, or you can always check between their toes, or even their tongue even. Their tongue will be a good indicator as well as what color their mucous membranes are. The color is important because that lets us know are they giving enough oxygen to the rest of their body. That means that if they're cyanotic or blue, that means that for some reason, for whatever reason, they're not able to get enough oxygen through their blood circulation to perfuse their organs properly. So that's why it's important to know mucous membrane color. Capillary refill time, it goes hand in hand with mucous membrane color. So essentially what you're going to do is just kind of press on you can do it with your own skin really. You just kind of take your thumb or finger, what have you, to the gum of the patient and just press on it, and it'll blanch or whiten, and you're going to count how long it takes for that blanching to go back to pink. And excuse me, if it's anything longer than 2 seconds, that means that the patient's not able to perfuse their organ properly. If it's anything less than 2 seconds, that's normal, that's fine, that's what we want. Pulse and blood pressure. Pulse and blood pressure, they kind of go hand in hand in the fact that whenever you're checking for heart rate, um, you kind of, when you're listening to, when you're auscultating the heart, you put your hand on the femoral artery. What you're listening to is the heart normal low ebb. For every pump, you're feeling for a pulse on the femoral artery. So if you're not feeling a pulse on the femoral artery with every heart sound, that means that there's not enough cardiac pump, if you will, to send blood throughout the caudal aspect of the body. That means that caudal organs in the body are not being getting enough proper blood flow, and then we can wind up with organ damage through like the kidneys, stuff like that. So, what else we got? Respiratory rate. Respiratory rate is a good indicator, especially for, it's a good indicator for pain. It's a good indicator for anesthesia, and it's good to know if your patient is able to, are they breathing so heavy because they're in pain? Are they breathing so heavy because they're too hot? Are they breathing so heavy because they're in shock? What is the problem? So for dogs, a normal respiratory rate is 10 to 35 breaths a minute. Obviously, if they are anesthetized, it will decrease. Personally, if my anesthetized patient is, personally, I like my anesthetized patient to have no less than 8, because I've had big dogs especially. 8, I'm kind of pushing it, but I can just bag them with the anesthesia machine, and they do perfect. But I don't like them to go any higher than 20, because that means that if they're anesthetized, if they're going any higher than 20, that means that they can clearly feel what's going on, not consciously, but their body knows what's going on. So, but yeah, normally it's between 10 and 35 breaths a minute in dogs, and in cats it's 20 to 30 breaths a minute. And again, a calm cat or an anesthetized cat, the same idea. Anything between, I want to say 10 to 15 is typical. But if it's going any higher than that, that means that the patient can either anesthetically feel what's going on as far as surgery goes, or like I said, if it's a calm cat, and it's typical for a cat to have like 15 breaths a minute, or a very active cat to have 15 breaths a minute, or a lower heart rate even. Respiratory rhythm, normal inhale, exhale, inhale, exhale. Like the sinus rhythm is normal. Anything that's where it's kind of like a shallow, that's, the patient's not able to get the proper oxygen flow through their blood and through the rest of their body. That's not normal. We want to know what's going on. Why are they not breathing properly? Does it hurt? Is there fluid on their lungs? Is there fluid around their heart? What's going on with that? So that's another reason why it's normal to know normal respiratory rhythm, respiratory rate. Body temperature, that was easy. Dogs and cats, it goes hand in hand. 99.5 to 102.5 is normal. Sometimes you get the nervous cat or dog that comes into the office and they will have a a temperature, and it's a little higher, a little elevated to about 103, 103.5. Anything typically higher than that we would consider a fever, just because it's, a nervous patient is not going to have a 103.8, 104 nervous temp. That's typically a fever. We would categorize that as a fever, especially if they clearly don't feel good. So, but if your patient's anesthetized and their temperature is normal, that's great. That's what you want. You want to keep their body temperature normal, so that way their organs are able to properly they're able to work properly. But if the temperature is lowered, that means that blood is moving slower in the body. That means that because the heart is pumping slower, because that's just the body's reaction to the lower temperature. So low temperature causes a decreased heart rate, decreased blood flow. If there's decreased blood flow, then that means that the organs are not getting that proper circulation of blood. If they're not getting a proper circulation of blood, that means they're not getting a proper oxygenation. So that's why it's important to have a good temperature. But if they're anesthetized, sometimes the temperature can drop. And that can also make recovery time longer for your patient. So sometimes they take a little longer to wake up, and they just don't do so hot. Sometimes they may wake up and their stomach may get a little upset and they might vomit a little. It doesn't necessarily mean that they ate the night before. It just means that they're very sensitive to the anesthesia, and it could be for a number of reasons. One of them being because recovery was rough coming out, because they, by the way, this is my work jacket. I just realized I was still wearing it. So this is my work jacket. I promise you I'm being professional. Anyway, so next is readings and monitoring devices. So that's what I have out. I don't have a stuffed animal. The only stuffed animals I have are my dogs, and she has ripped limbs apart from my stuffed animals. So I don't think that you want like a two-legged rabbit. So I didn't bring a stuffed animal. But that's what I got the monitor here for, to show you that readings and monitoring devices, they're pretty self-explanatory. EKG would be these top lines. If I had the EKG hooked up, that would be the one with the leads, the different leads. Like I said, this is a 5-lead hookup, but we only use 3. Typically you can use 4 in a veterinary office, but we only use 3 today. But it would give you the normal PQ and RS waves and all of that through here, these 2 lines, and it would give you your heart rate right here in this green. This yellow is our pulse oximeter, or saturated oxygen, or hemoglobin, oxygen saturated hemoglobin, right here, and it also monitors respiratory rate, as well as a little bit of heart rate, kind of, to an extent, but it'll give a normal wave throughout here, and that's it's not, that number will come up right here. And then the NIDP, which is non-invasive blood pressure, that'll give you your systolic and diastolic number readings right here, and then it'll give you your average right about here. And then CO2, if we had a capnograph or an end-tidal carbon dioxide output, that would be right about here. But like I said, we didn't have a capnograph today. And then the esophageal stethoscope is just essentially just an auditory thing that you would listen to for a heartbeat. You know if you're not hearing a heartbeat, then it just immediately gets you your attention. I'm sorry, I'm going to have to pause my video. My camera's trying to die on me. Okay, so I am finishing up my task 6 monitoring anesthesia with anesthetic chart. I'm not using any notes again. I'm just using the video instruction sheet, so that way I know what to cover. There's nothing written on the back, obviously. So that's what I'm looking at over here. You can even see there is nothing over here. Let's see. Nothing over here. Anyway, so let me get you situated again. So essentially, I think I left off after readings of monitoring devices, and that was yesterday. and I was on call last night, I ended up getting an emergency come in, and by the time we were done with the emergency, I didn't feel like finishing the video, which is why I'm wearing a different shirt. And so I just went home. So now I am finishing the video. So I am going to finish. I'm going to try to remember what it is that I said, because I didn't look back at the video to see what all I had said. But as far as readings and monitoring devices, I had to return all that equipment that we had borrowed to the neighboring veterinary office, and trying to remember everything that I had said. But so essentially, what you want to know is that the pulse oximeter is reading everything properly. The oxygen saturated hemoglobin, that means that as much oxygen that the animal is breathing in is actually oxygenating the blood properly, and the capnograph actually measures the output of the carbon dioxide of the patient. So with input, or the intake of oxygen, that's pulse oximeter, and then the output of carbon dioxide, that's the capnograph. We don't have a capnograph. We did not have one available to us to borrow, but as I stated before, it would be placed between the endotracheal tube and the anesthesia machine tube, or the inhale-exhale tubing, straight to the anesthetic machine. And that essentially just, it helps measure the CO2 output as well as the respiratory rate. So, and then the EKG measures the heart waves and also the heart rate. And like I said before, it gives you the PQRS and T waves, and it also lets you know that if there's any sort of arrhythmia, it'll let you know what that heart rate looks like, not heart rate, heart wave looks like, and where is the arrhythmia at specifically, whether it is in depolarization or in the repolarization portion of the heartbeat itself. So what else we have? We have the blood pressure monitoring cuff. That obviously, self-explanatory, measures the blood pressure of the animal to make sure that the blood pressure is maintaining in the body, that there's good flow of circulation through the rest of the body, that the heart is able to, I feel like I'm just repeating myself, that the heart is able to pump enough blood throughout the rest of the body. I really don't know how to explain it other than that. And that the rest of the limbs and the rest of the body is able to have adequate perfusion and oxygenation, that sort of thing. So, and you read it as systolic over diastolic. So, like for instance, like 120 over 80, I want to say that's a pretty decent blood pressure. I'll be honest, I'm not very good with blood pressure readings. So, what else? Cover the EKG, capnograph, the pulse oximeter, blood pressure, respiratory rate. I think I already covered that in the previous video. The esophageal stethoscope really is just it's an auditory monitoring device. Really, you're just kind of listening out. You can either do that with an actual earpiece stethoscope attached to the esophageal probe that goes into the esophagus and at the level of the heart, and listen to the heartbeat that way, or not, yeah, the heartbeat that way, or you can put it on an amplifier, which is what we have, and it's super old school. You heard it on the video. It sounds exactly like an amplifier, creating a lot of static, and it works when it wants to be honest. So it's the way my teacher, or not my teacher, my doctor described it. It's one of those things that it's not that it's unnecessary. It's just that you can do the same thing with just an ordinary stethoscope, whereas this one and the esophageal stethoscope, it just is a constant thing that you're constantly hearing it. So if there's any kind of arrhythmia for some reason, or if you just hear the heartbeat just skip a beat, you will it automatically like just tunes you in, like, oh, that's not right. Let me check on this patient real quick. So the circulating anesthetist or technician during surgery can actually kind of walk around and do their thing and kind of keep an ear out, sort of thing. Same thing with the pulse oximeter. That's another thing that while I was doing that surgery, with the pulse oximeter, it was actually, well, it was irritating, something I wasn't used to. It was kind of reassuring, the fact that, I can hear the patient's heartbeat kind of with the beeping of the pulse oximeter, because it also measures the heart rate as well, and I knew it was measuring my heart rate because as I was listening to the patient's heart with my stethoscope, I could hear every beat for every heartbeat that I was hearing. So I know that it was measuring the heart rate, and it was actually very, very close, maybe 2 beats off. That's it. Or maybe my math was just wrong. Either way, it was very close. And so those are the readings of monitoring devices. Why those are important. I'm gonna move on to the reflexes portion of this. The ear flick reflex. Typically, that one is a little unreliable in the fact that it could potentially stay with the patient if it's still really, really light, or if it's just one of those patients that their ears are really ticklish. So that one we don't typically use, but essentially what you do is you just tickle the ear or the ear hair of the patient, and just like if you were just messing with your dog or your cat at home, you tickle that ear hair and it just kind of flicks. And that's when you know, kind of gives you a good idea of the depth of anesthesia that the patient is in. Or you have the pedal withdrawal reflex. That one's pretty simple. We use that also to find out for any pain reflexes for any patients who are exhibiting neurologic deficits. So pretty self-explanatory. You pinch the toe of the patient, and any toe essentially. You pinch it, and you're pretty much supposed to put in a lot of pressure, enough that in any normal case would hurt the patient. You're not harming the patient, but you make it uncomfortable. Just like anybody, you don't want to be pinched, so you just like a reflex, ow kind of thing, you draw back. Same idea, pinch that toe, you put a lot of pressure on it, and the idea is that if they pull back on that foot, they're too light in anesthesia. What else? We have palpebral or wink reflex. That is real easy to do. You've seen me do them on a couple of my videos, where you'll just like press on the medial or even the lateral canthus. I usually use the medial canthus of the eye, and my eye will do it too. You can do it to yourself, and it's just a reflex thing. You cannot help it. And especially patients who are anesthetized in any lighter plane of anesthesia will do it. just tap on the eye and it'll actually blink or kind of wink a little bit, and that's a really good indicator. That's probably the more common used one for anesthesia, anesthetic depth, and corneal reflex. So corneal reflex is where you just touch the cornea of the eye, and you usually use it more in large animal surgery because usually large animal surgery they will have more nystagmus than anything. Sometimes it's throughout the entire procedure of surgery, so it's hard to tell when a large animal how deep they are in anesthesia because they're essentially the same throughout, so you have to be really vigilant in what you're doing as far as large animal goes. So sometimes you just tap the cornea and the globe will actually recede back into the socket. Another reason you would do the corneal reflex is if you're euthanizing. So again, just tap it. If it reflexes or recedes back into the skull, that means that the patient is still pretty light in anesthesia. But as far as euthanizing goes, that's the only way. If it does not retract back into the skull or back into the socket, that means that the patient is dead. Or the patient is extremely deep in anesthesia. That globe will retract regardless. It doesn't matter what it is that you do. It's just a natural thing that the eye does to protect itself. So that one's not very reliable. We don't usually use it a lot. Plus, you really don't want to stick your dirty fingers into a patient's eye, gloved even. I wouldn't even put a sterile gloved hand or finger onto a globe of an eye just because I don't want to damage the eye in any way, even if it is sterile, even if it is gloved. Just don't do it. Don't do it. Unless you're euthanizing, then it really doesn't matter. Laryngeal or swallow reflex. That one is super easy. That one you want to use for whenever you are intubating. If they are swallowing, swallowing is more of a conscious reflex. If they're swallowing, they're really, really light in anesthesia. You don't want them to swallow if you have them in a perfect plane of anesthesia. They should not be swallowing. But when you're intubating, if they're swallowing, it kind of makes it a little bit difficult. So that's why you want to wait till after they get done swallowing to be able to, for their epiglottis to actually open up, so that way you can see down into the trachea. The swallow reflex is actually another good indicator to let you know that your patient is recovered enough that you can actually extubate them, that they are able to swallow on their own in case they were to get an upset stomach from the anesthesia. Sometimes some patients are really sensitive to the anesthesia, and I mean we even do it whenever we wake up out of anesthesia as humans. You just get a little bit nauseous and we just vomit. Our animal patients will do that too. So if they're swallowing, that means that we know that they're not going to aspirate. Usually, I usually try whenever I'm extubating my patients, and they do have a swallow reflex. Usually try to do it at least 3 times, pull on that tongue to stimulate a swallow reflex. I even try to push the endotracheal tube back and forth just a little bit. You don't want to push it back and forth, just a little bit, just to kind of tickle it. And you'll either hear them start coughing, and that's another indicator that they are waking up to extubate. But like I said, it'll also stimulate that swallowing reflex, and they'll start to kind of thing and try to push it out of their throat. So, but once you extubate them, they start swallowing. You know that they're conscious enough to be able to regurgitate anything back up on their own without aspirating it typically. But once I do that, usually I just kind of turn them sternal, because when I extubate them, they're recumbent laterally, so I usually try to turn them sternal, so that way in case they do vomit anything up, they're already in that position to go ahead and vomit. But the swallow reflex is actually a very good indicator to let you know what anesthetic depth your patient is in. Usually you're looking at swallow reflexes if they're going into a deeper plane of anesthesia than what you want, or you're looking at it to go into a lighter plane of anesthesia than what you want, meaning you're wanting them to go down enough to stop swallowing, just breathe in the good juices, and go to sleep. Or you're wanting them to wake up, come on, I need to get this tube out of your throat, that sort of thing. Jaw tone. Jaw tone is a good indicator, definitely. I don't know how many times we have been trying to intubate a patient, and the jaw tone, somebody's premature, we're trying to intubate, and the assistant will lift the dog's mouth up. The doctor will go in to open the dog's mouth, and the jaw tone is still really tight, and still very, very much so present. And they go to open the mouth, and the dog either sneezes, or they just bite down harder, and the doctor now has a bit finger. How many times it has happened. So after the patient has been induced, typically you want to, at least what I do anyway, you try to wait a couple seconds, especially after you flush that catheter. Another good time with saline flush, just wait a couple minutes, or not minutes, but a couple seconds, and just wait for that medicine to kind of take effect. The jaw tone will tell you whether or not it's safe enough to intubate, because it'll be kind of slack. It's another good indicator to let you know that if it is slack on when you have the patient hooked up to anesthesia, the jaw tone with other parameters, obviously. If the jaw tone is slack, then, or flaccid is what the book calls it, I like to call it slack. If it's slack on the table when you're having the patient anesthetized, then that's a pretty good indicator that the patient is well anesthetized. They're at a good plane of anesthesia. But if it's still pretty tight and they're still trying to chew and swallow, your patient is entirely too light. They're still a little bit aware of what's going on. With jaw tone, eye position is also a very good indicator. So if your patient's jaw tone is really, really slack, like they're essentially a lymph noodle, which is good anesthetic claim, but you also want to check your patient's eyes. Where are your patient's eyes? If they're rolled forward and they still have jaw tone, that means your patient's too light in anesthesia, and they still have a reflex, a palpebral reflex. That means that your patient is too light in anesthesia. If your patient's jaw tone is slack and your patient's eyes are rolled down, or they kind of look like they're rolled inward, medially and down, they kind of look a little cross-eyed, that means that they're essentially, they have no palpebral reflex. So no palpebral reflex, eyes are rolled down, and slack jaw tone. That is a very good indicator. Those are the three things that I look for when I know that my patient is at a good plane of anesthesia, along with a regular heart rate, regular respiratory rate, regular respiratory rhythm, and color looks good, that sort of thing. But those are the three things that I look for. When I'm anesthetizing my patient. So, but if your patient is slack jaw tone, eyes are rolled forward, no palpebral reflex, means your patient is too deep in anesthesia. You're actually on your way to killing your patient if you don't do anything about it. So, start checking your patient's heart rate, check their respiratory rate, check their gum color, check their temperature. Those are the sort of things that you would check if your patient, their eyes have started to roll forward. Like I said, they don't have any reflex, their jaw tone is slack. Like I said, your patient is on their way to dying. They're not dying yet, but they are they are just starting that trip to go see Jesus. And so it's very easy to get your patient in too deep of anesthesia. Very easy if you're not paying attention. And but it's also very easy to keep your patient in a perfect plane of anesthesia. And the respiratory pattern, I've already told you that. The respiratory pattern is something that it's very simple. Inhale, exhale, with a little bit of a pause. Inhale, exhale, a little bit of a pause. One inhale, one exhale is one breath. Simple. If your patient is too deep anesthesia, they will have either decreased respiratory rate or rhythm, or they will have a jerky respiratory rate or rhythm, usually respiratory rhythm. And if they are entirely too deep, if they're entirely too deep, they will usually have no respiratory rate at all. That means that your patient is in respiratory arrest, and they are on their way to cardiac arrest. That's typically the first thing that happens if your patient is in too deep of anesthesia, respiratory failure, and then cardiac failure, or arrest, if you will. So, like I said, it's very easy to get your patient too deep, but it's also very easy, if you know what you're doing, to keep your patient at the perfect plane. But if your patient is jerky, you know how that is described. It's described as jerky. The reason why it's jerky is because the patient is the thoracic muscles are too kind of weak because of the anesthesia and the medicine is running through their system. There's not enough oxygen throughout the system because the thoracic muscles have decreased in their movement. So now the stomach muscles or the abdomen muscles are trying to help the thoracic muscles to push the lungs, to contract the lungs, to get some oxygen flow and some CO2 output. So what you find is the patient goes when they're breathing. That means that you're on your way to respiratory arrest. If your patient is breathing like that, you got them entirely too deep. You need to start turning down their oxygen, or not turning down their anesthesia and turning up their oxygen because they're not getting enough oxygen. You've had them under for too long, and that you've had them too deep, too long, and it's no bueno. So I keep talking about planes, different stages of anesthesia. So first stage of anesthesia is how would you call it? Disoriented, really, is what calls it, I think. And they kind of struggle a little bit with you. It's kind of pre-medication does stage 1 and stage 2 typically for anesthesia. So stage 1, they're a little disoriented and they try to, obviously all reflexes are present because they're still conscious. But they're kind of less aware of their surroundings, if that makes any sense. Stage 2, in stage 1, their heart rate is normal, their respiratory rate is normal. Stage 2 is the excitement stage. They usually are vocalizing, they are paddling, their heart rate is a little bit elevated, just a little bit, and all reflexes are still very much present. And they may struggle with you still a little bit, especially if you're trying to perform surgery. Stage 3 is actually broken down into 3 planes. So stage 3, plane 1 is light anesthesia. They're anesthetized, but they're still very light. Palpebral reflex will be present. Maybe an ear reflex will be present. Obviously, corneal globe reflex will be present. the pedal pinch reflex, pedal reflexes will be present because they still feel pain. They're a little less aware. They're even more so less aware of their surroundings. And then stage 2, no, stage is 3. It's 4 planes of. Stage 3 is broken down into 4 planes. I think I said that wrong. So stage 2 is a little deeper. Still not quite the perfect anesthetic plane that you want your patient at. There are less reflexes present. Your flick may not be there. Your palpebral reflex will still be there. The pupillary light reflex may be diminished. The patient may start just to be rolling down at this point. The pedal reflex may be diminished. It may not even be there at all. Doesn't necessarily mean that they're at a good plane yet. And then stage 3, that is usually your ideal plane. So stage 3, plane 3, that is your ideal plane of anesthesia that you want your patient to be at. So that means that they have no reflexes whatsoever, except for that corneal globe. It'll always be there. Your eyes will be rolled down. Heart rate will be perfect. Respiratory rate should be perfect. And there should be absolutely no pedal reflex whatsoever. This, like I said, this is the perfect plane to start whatever procedure you needed your patient to be anesthetized for. Then stage 3, plane 4 is deeper than what you want your patient to be. This is where the patient's breathing might start to become jerky, that sort of thing. Eyes are starting to roll forward. There's still no reflex. Jaw tone is slack. Your heart rate is decreased some, if not significantly, and your respiratory rate is decreased significantly. Mucous membranes may even be pale. Like I said, this is where your patient is starting to head to the direction of dying. And then there is stage 4, not plane 4, but stage 3, plane 1, stage 3, plane 2, stage 3, plane 4, and then you have stage 4. Stage 4 is where your patient is dying. Mucous membranes are pale, if not white. They may even be a little bit cyanotic, even though there is oxygen being delivered to them. But if the patient is not breathing, then there's no oxygen being delivered to the body. So if there's no respiration, then there's no oxygenation. If there's no oxygenation, then there's no circulation of blood. So that's what I was saying earlier. Usually, if the patient is too deep of anesthesia and they are dying, respiratory arrest is usually the first to come. There's no, like I said, there's no respiration, then there's no oxygenation. If there's no oxygenation, then there's no circulation, which is cardiac arrest. This is where you need to resuscitate your patient. Your patient is coding on you, and this is not good. You're not paying attention to what you're doing, and you're killing your patient. And different patients do this differently. You may not even be aware that your patient just went from one plane to another without really realizing it. Older patients, you actually may need to keep on a lighter anesthetic dose than you would, say, a 6-month-old puppy, because they are just not the older patients are not able to metabolize the anesthesia properly. we actually had a Yorkie who was only 6, 7 years old. We were spaying her, and the technician wasn't, she was paying attention, but she wasn't paying attention to the patient's heart rate, and did not realize that the Yorkie had actually slipped below 115, and actually when I took over for her, she went to lunch, I took over for her to monitor the patient throughout the rest of the procedure, and her heart rate was actually at 70, and her respiratory rate was at 6, and she was, my battery's trying to die on me again, but the patient's respiratory rate was at 6, and mucous membrane was pale. We had to quickly put her on fluids to warm her up. I lowered her anesthetic dose, and raised her oxygen intake, and bagged her a couple of times, made sure that she was receiving enough oxygen. But like I said, it's very easy to put your patient in too deep of anesthesia, but it's also very easy to maintain your patient at perfect anesthesia. I think that I covered everything. Like I said, I did not use any notes. I just used this to kind of make sure that I covered everything. I wish I had more, what's it called? The visual aids. Like I said, my dog chews up all stuffed animals. I only had the few anesthetic monitoring equipment that we borrowed. I really wish that I could have showed you more with it, but like I said, that emergency came, and I was too tired by the time we got done with it. So I hope that is it. This is my last video.